Good day, everyone. Welcome to my IVF Fences. We are back with one more webinar today, and I'm glad to be here back with Dr. Oliver Pack. You can see him right here. Hello, Dr. Pack. I hope your
Hello,
day has
good
been great.
evening.
Good evening, and I'm glad that you are back. And
Thank you.
I hope that you are ready to educate us a little bit more on our topic, which is definitely an interesting topic,
Yes,
PRP. So how have you been? How are you?
I'm fine. Just said goodbye to my last patient, and now ready to go with this. Actually, really, it's a very interesting topic. We have a lot of experience with PRP already, so yeah, you will enjoy my talk.
Definitely. I'm sure about this. So before we start, as always, let me just briefly tell you that we will start with Dr. Park's presentation, but afterwards there will be time for your questions, so you can put those in the chat. And Dr. Park will definitely answer them for you right after his presentation. Don't hesitate. This is the time dedicated for you. So don't hesitate. Anything that's on your mind, we are here to help you out. And of course, remember that if you wish to volunteer, we are still looking for some volunteers. And my email is in the chat. So if this is something that you think you might be interested in, get in touch with me. I'll be happy to give you some more details on that. And now I think we are ready to discuss PRP. Dr. Pack, let's begin. The presentation is here. And let us know, everyone, if you can hear us loud and clear. I think everything is working perfectly, but just in case, let us know if it's all okay. And I think we can start, right?
Okay, is my
Brilliant.
audio? Can everybody hear me?
Let us know. I can hear you perfectly, and I think
It
everything
should
is
be fine.
okay.
It should be fine.
So let's
All right.
go.
All right. So yeah, let's start to speak about this. The topic of today: uterine and ovarian rejuvenation with plasma rich in growth factors. So this is a treatment based on the effects that the growth factors have on human tissues, different kinds of tissues. It can be applied in many places. Everywhere where cells are growing, these growth factors can take their effect. That's why it's used widely used in medicine in general, in many different places, as I explained. So, what is autologous plasma? Autologous means obtained from the patient's own blood. So it's obviously when it's coming from the own blood of the patient, it's a very, very secure treatment that does not have any side effects, which is one of the big advantages of PRP. The growth factors are contained in the platelets. The platelets are the part of the blood that forms the blood clotting, that makes a blood vessel stop bleeding. Okay, these are the platelets, and these platelets contain growth factors. So PRP means the plasma from the blood. We take out the red blood cells, the white blood cells, and we leave the platelets there, and we just concentrate these platelets in the plasma. That's what PRP is. So it was first used in heart surgery. Heart surgeons struggle to make hearts work when heart tissue has died. So they were the ones who first used it a long time ago, 1987, with the purpose to regenerate heart muscle in patients who have lost heart muscle due to myocardial infarction. But then many different fields in medicine started to use it. Orthopedics are using it for joints, for muscles, for tendons. In cosmetic, skin, it's clear skin has also many places where skin has to be regenerated. It's used in surgery, it's used in wound care, it's used in ophthalmology, neurosurgery. Dentists also use it to regenerate the for periodontose. So it's effective everywhere where tissue has to be regenerated or where cells have to be stimulated. It can be applied. So we started to use a PRP in the uterus, and we were actually the first clinic. We are pioneers in this. We started to use it in 2015. So 8 years ago, in patients where who struggled to build a good lining. When we transfer an embryo, we need an appropriate thickness of the endometrium. The perfect thickness is more than 7 millimeters, but there are many patients who struggle to build up a good lining, and we call it atrophy, and this is where we started to use it. And 3-4 years ago, we also started to use it in the ovaries. Let me just switch. This is a machine where the PRPs are concentrated. So what are the effects on tissues? It promotes circulation. Angiogenesis means the formation of new blood vessels. It stimulates cell migration, proliferation. It reduces inflammation. It stimulates the secretion of other growth factors. And in the endometrium, it has been shown that endometrial fibroblasts grow and start to move stronger, so a thicker lining can be achieved. These mechanisms are investigated, but we can also see it. It's not only visible in the lab. We really see that the lining grows much better after a PRP in the majority of our patients. It has a clear effect in terms of thickness. So so we have two types. We have the ovarian and the endometrial PRP. We started to use it first in the endometrium, and 2-3 years ago, also in the ovaries. So what are the indications to use it? In the lining, endometrium means the lining of the uterus. Asherman syndrome is very common, especially in women who've had curettage, which means miscarriage that requires DNC. Adhesions are very common, so the lining is not growing the same way anymore. This is a very common indication. And sometimes you see that the lining is just not growing and you cannot find any reason. Even when you look into the womb, there's no apparent reason why it's not growing. They just don't build a lining more than, we have had patients where the lining cannot grow more than 4 or 5 millimeters, which is very thin. Chronic inflammation that has already been treated with antibiotics is another indication. Chronic endometritis means infection and inflammation. And implantation failure has become an indication. We didn't use it at first because firstly the indication were patients with atrophic lining, where the lining wasn't growing. But then after a few years, we observed that even in the patients where the lining didn't grow, because it doesn't work in all patients, but still we observed higher success rates. Not only me, all my colleagues, we all saw that. We don't have clear statistics about that, but it became clear very soon. We've had stories like my most particular case was a woman who tried to achieve an appropriate lining for transfer for several years. She didn't make it. I didn't achieve it either. The maximum thickness of lining I achieved in that patient was 4.5 millimeters. At the end, we decided to make a transfer with that lining. We decided to make PRP. Okay, she was very busy, so PRP requires some time and some dedication and also availability. So it took a long time till she came, and finally we did the treatment, we did the regeneration cycle, and she had we transferred the first embryo. I remember the thickness of the lining was 4.7 millimeters. So basically it didn't grow better than before. So I said, wow, that doesn't look so good. But anyway, we had to do something. We transferred the embryo and it was successful. Well, I would like to tell these stories more often. Unfortunately, it's not always like this. Many times it doesn't work. But these kind of spectacular successes, not only me, but also my colleagues could tell stories like these, like this one. So it became clear that somehow the lining was also improving quality, receptivity. And that's why we are also using PRP treatment in women who have had repetitive implantation failure. And also miscarriage, because the causes of implantation failure and miscarriage are often the same. Ovarian indications, it's clear when the egg reserve is low. Now, ovarian regeneration or rejuvenation is a bit misleading because it's actually not true that the ovary becomes younger. It's not true that we are regenerating anything here. Okay, we are not regenerating eggs because eggs cannot be generated. The ovarian reserve is called reserve because the eggs are there and you're spending them every month till it's zero, till they're gone. So when the reserve is low, which can happen sooner or later, there are women who have a very low ovarian reserve, even in early ages. We have many cases of premature ovarian failure. So this is obviously one of the main indications. So what do we achieve here? In this case, it's not that I told you before, we don't regenerate eggs, but what we can achieve is that the ovaries become more active. Because women with low ovarian reserve, it's not that they don't have eggs anymore. And the thing is that the eggs that are getting prepared for growth, I mean the antral follicles, these are the follicles that we can stimulate. And the number of antral follicles is the potential number of eggs that we can achieve. So if there are only 2 antral follicles, we will have 1 or 2 eggs only, maximum 2, rather 1 or none. So that doesn't make a lot of sense to make stimulation when the ovarian reserve is so low. So this is where PRP comes into play, because it's not clear whether it will work, but when it works, then there is a clear increase of the number of follicles that are getting prepared for growth. The number of, we call it antral follicle count, increases. And as AMH is produced by these antral follicles, also AMH increases. And this effect can be observed soonest a month. Sometimes it takes 2 or 3 months. Between 1 and 3 months is required to observe this effect in women where it's where we have a response. Unfortunately, and this is the big problem of PRP, it works only in 30-40% of our patients. And there is no way, we don't have any tool to detect, to determine which patients will respond and which patients will not respond. So there's only one way for now. Right now, there's only one way to see whether it works or not. It's trying, just trying. So indications: premature ovarian failure, it's clear, which is probably the best indication because these ladies are relatively young, so ovarian quality is much better. Age is really key in IVF. So it's not the same doing a PRP in a 35-year-old than in a 40-year-old or over 40. Chances in a 35-year-old are much, much higher than in a 40-year-old because of egg quality. Premenopause, natural menopause, these women have ages range between 40 and 50 years. It becomes really difficult. It's a way how you can, some of these women still have a relatively good egg reserve or follicles. If it works, if PRP works, you can double the number of follicles, which doubles the chances. But the chances, the general chances to succeed are very, very low, when the woman is over 40. Even with PRP, this is not a game. PRP is not a game changer here. Okay, it can increase the number of follicles, but it will not significantly improve the egg quality of the eggs contained in these follicles. So yeah, low ovarian reserve, and also it can also help in cycles where we achieve embryos, but the embryo quality is low, or number of embryos, or the quality of the embryos is low. So the more eggs we have, the higher the chances. So in women where ovarian reserve is already descending, which normally occurs around the age of 35, preferably before the age of 40. This is the best moment when the egg reserve is not yet zero. Okay, when egg reserve is around, let me convert our units. Well, we say that there's a minimum AMH below which it starts to become really difficult, but I know that in UK you use a different unit. So let me just convert it. It's 0.5 nanogram per milliliter. That corresponds to 7.2. So if the AMH is lower than 3.5 picomole per liter, this is where egg reserve starts to be really low. And when it's between 0.5 and 1, this is a very, very good indication to do PRP. Well, because it's not the same. When AMH is really low, if it's close to 0, or if it's below 0.1, and if the woman is over 40, even when it works, even if we achieve a better number of eggs, still these eggs will have a low quality, and instead of 2 eggs, we might have 4 eggs, but it doesn't. This doesn't make a big difference at the end. It's likeliness to fail. It's very, very low chances to succeed, very low. But in women where the egg reserve is still, it's low but not very low, so between 3.5 and let's say 6 or 7, this is intermediate egg reserve. Here it's a really good, because if you double the amount of eggs, if you might have normally you would have like between 5 and 10 eggs, and suddenly you can have 12, 15 eggs, and that can make a big difference. So this is where I most like recommending PRP in women where egg reserve is not very, very low. And if egg reserve is very low, then it's a big advantage if she's under 40, if the patient is under 40. Yeah. So let's continue. So the development of stimulations, the planning and the scheduling, this is a typical scheduling when we always have to wait for a menstruation to start a stimulation. So we would make a first stimulation, and during the egg retrieval, this is the very best moment to apply the PRPs for purely logistic reasons, because the woman is sleeping in the theater, and there is an anesthetist, and it's very easy once the eggs have been taken out to infiltrate the PRPs. So you combine a first stimulation and a first egg retrieval with the application of the PRPs. Then you have to wait 1, 2, sometimes 3 months, it's not clear, until these PRPs take effect. Then you can do a second stimulation. We call it embryo banking. Embryo banking is one of the main reasons why people come to Spain, because we collect embryos. In order to collect between 4 and 8 embryos, this is the number of embryos where, when you send these embryos then to pre-implantation genetic testing, and it comes back that there are, if you have, let's say you have 5, in a 35-year-old, there should be 3 euploid embryos, more or less. In 40-year-olds, there could be only 1 or 2, but still, we are speaking about euploid embryos. A euploid blastocyst has a very high chance to succeed. Pregnancy rates between 70 and 80%, and live birth rates around 50%, 50-60%, very high. But strongly age-related, very. Age is really a big modifies the lowest chances the higher the age. Over 40 is really a bad predictor. So this is the process of an egg retrieval. It's a needle mounted on the ultrasound probe, and you get into the follicles. First, you empty the follicles, and then you, when you're done, you inject the PRPs with the needle as well into the ovaries in 2 or 3 different places. You just infiltrate it in both ovaries. We also have had women who came only to do the PRP without an egg retrieval. That's also possible. It's more expensive because you have to pay the surgeon and the theater only for the PRP. Okay. So once the PRP are infiltrated, we make like a monitorization of the follicles and of the AMH. The first control is usually recommended. I recommend to do it after each with each period. Then you can also decide to start a stimulation if you see that there's a good response, because you're doing a basal scan. So and you determine AMH that day, and then you could, if it has increased, you can directly go for another stimulation if there's a good number of follicles. Okay, but possibly in the first scan there is no result, but in the second or third period, you know, each cycle, with each bleeding, you go to your gynecologist and make the AMH and the follicle count. And this is how we can detect whether the PRPs have taken effect, and if so, directly go ahead with stimulation. So what is the longest time I would wait? I think that if after 3 months or 3 bleedings after the infiltration there has been no effect, then I think it's a negative result. Unfortunately, I mentioned before, 30-40% of women is where it's working, and 60-70% of women, there is the effect. There's basically no effect. It doesn't work. Okay, the protocol improved ovarian reserve markers. So we speak about the FSH might go down even in women who are perimenopausal, where FSH has already increased, which is one of the first signs of menopause. Sometimes this goes down. We've had women who have restored their menstrual cycle. This is incredible. You know, we had just recently, and also that was an incredible success story. That was a woman with premature menopause, premature ovarian failure was the diagnosis. She was 32, so relatively young, and she restored her cycles. She had stopped having cycles many years ago, and after the PRP, she started having cycles. We did a stimulation, and it was successful. We succeeded in the first attempt. This was one of the few really success stories where we could say, okay, PRP finally succeeded with a baby in her arms. Unfortunately, these stories are not so frequent, and it mainly happens in women under 40. Potential improvement of embryological reproductive outcomes after genetic metastasis therapy. That's clear. All the parameters of an IVF cycle might improve. But the main effect is based on the fact that we have more eggs. So endometrial PRGF treatment. PRGF is the same as PRP, only that we do not concentrate the platelets, but the growth factors. That's why it's called PRGF. So this is a scheme of a uterus, of a lining, and these pictures here show how we infiltrate, basically it means inject the PRPs into the basal layer of the lining. But we can also apply it by instillation. Not installation, is instillation. Instillation means we just wash these PRPs into the cavity by with a transfer catheter. So the process is basically same as a transfer. In our endometrial regeneration consists first in a hysteroscopy, which is performed just at the beginning, just when the woman stops bleeding. This is the moment when you can do the hysteroscopy and infiltrate the PRPs. And then during the growth of the lining between day 5 and 14, 15, during these 10 days, we usually perform the instillations where we wash the PRPs into the cavity. And and then we start to give the progesterone, and a few days later transfer. This is a typical. Okay, embryo banking strategy plus PGTA. I mentioned before that's what most people come to Spain to do precisely that, to collect embryos. So they perform several stimulations. It's more and more common that we infiltrate the PRPs in the first egg retrieval, which is relatively cheap and easy to do. And then, so it's the indication AMH below 1.2 nanograms per milliliter. This I mentioned before. Yeah, AMH between 0.3 and 0.7. Sorry, between 3 and 7 picomole per liter. This is the unit you use in UK. This is the indication, the best group of patients where it really has good increase of number of eggs, and where we really think that it can help. So how many cycles are indicated? Between 2 and 4 IVF cycles. Some couples do even more, but it's very, very hard. You know, couples have to come here for a week for each stimulation, and it's very cumbersome, and also psychologically and also financially it's expensive. So I think 2, 3, or maximum 4 cycles is reasonable. Depends upon how many embryos you can get. You see in each cycle, you see how many blastocysts you have achieved, and then you decide whether you want to do another cycle or not. So people usually do between 2 and 4 cycles. Normally, we recommend that there should be 1 or 2 months here in this. In this diapo here, we see 0 or up to 3 months. 0 means that sometimes we also do duostim. Duostim means that you do not wait a cycle till you start another stimulation. You start immediately after the egg retrieval, you start a new stimulation. But I usually prefer my patients to have at least a month in between. So every 1 up to 3 months, we can do a new cycle. So my patients usually, it takes them like 4 to 6 months to collect embryos. And then you send all the embryos, or let's say not the embryos are frozen, but we send the cells we took from these embryos all together to the lab. That saves costs, and you analyze all the embryos together. And then, then you have to pray that there are euploids. That strongly depends upon age. A 50-year-old, a 35-year-old, her euploidy rate is probably around 60%. A 38-year-old, 50-50, 50 are euploid, and when she's over 40, only 1/3 of the embryos will be euploid. So how many embryos, how many blastocysts you should collect strongly also depends upon age, and also on how many kids you want. If it's clear that you want more than 1 kid, then if you want 2 kids, then you have to collect the double number of embryos. then you have to collect 8 or 10 embryos. Depends upon many factors, but basically on age. So yeah, embryo quality largely depends on female age. Nonetheless, if we detect if we have a euploid embryo with 46 chromosomes, then chances are really high, with very high implantation rates, between 70 and 90% implantation pregnancy rate. Then the woman can still have a miscarriage. So live birth rate, if the uterus is fine, if there's no other obstacle, then chances to have a kid is really high, probably around 60%. Miscarriage rate is very high, but that's natural. Okay, every pregnant woman has a chance to have a miscarriage. 25, 30% of pregnancies end in miscarriage, regardless where the embryo comes from, whether it's natural or IVF, it doesn't matter. Okay, yeah, this is basically what I wanted to talk about. And we can start with the round of questions. So let me just widen this window here.
Brilliant, Dr. Pak. Thank you so much for your presentation. I'm here, of course. I will show you the questions one by one in a minute, so don't worry, all is here. So thank you for your explanation. And now it's your turn. So if you have any questions, there are some questions ready, but if you have more, you know what to do. And let's have a look at the first question here. So does PRP improve equality? My last 4 blastocysts were aneuploid and I'm 41 now. I have this, yeah, aneuploid for sure. Yeah.
I told before, unfortunately, PRP does not improve the genetics of the egg, especially aneuploidy strongly depends upon the age of the eggs, and this is something that PRP unfortunately does not improve. No. And this woman in particular, if she has had 4 aneuploids, she's 41, a 41-year-old, 25-30% is the euploidy rate, or she just had bad luck that there wasn't. Well, there was supposed to be at least one euploid. One euploid was statistics, and she had none, so she could try again. Yeah, this is. But her euploidy rate is probably very low, lower than the media.
All right. Thank you so much indeed.
If we do PRP, we can achieve more eggs, more embryos, and increase chances to find a euploid. That's what PRP can do.
Okay. Thank you for this, and let me have a look. More questions are coming in, so let's see. Thanks for elaborating this topic. Would you please explain when exactly and how many times to do PRP before IVF?
When exactly? The best moment, you can do it whenever. You can apply it in any moment of the cycle, or even a menopausal women. It doesn't matter. Then it takes between 1 and 3 months to take effect. And we have not yet so much experience to apply it several times. Usually we apply it once in the first egg retrieval. Some couples decide to make a second application, but there's no scientific evidence that successive infiltrations are better or might improve the outcome. So I think for now, 1 time, maximum 2 times. This is to answer the question. Yeah, or you apply it when we usually apply it, which is during the first egg retrieval. So with the purpose to collect embryos.
Brilliant. Thank you so much for your question. Hope that helps. If you have any follow-ups, you know what to do as well. Okay, next question is up. So how long does it take, more or less, for the effects to show in terms of knowing when to proceed to IVF? Can someone undertake the treatments back to back?
The treatment follow-up, we make the follow-up of AMH and follicle count. And I think the best moments to do this monitorization of both AFH, antral follicle count, and AMH is in each successive cycle after the PRP. You have to wait at least a month to do the first, and I would always do it when you have a period, because then if it works, then you might suddenly have a very high number of follicles, and you detect an increased AMH. And if it's spectacular, if it's really good, then you might decide to start a stimulation. So this is why I think the follow-up scans should be done with every bleeding.
Okay, yeah, thank you so much. And there's one more follow-up from our previous patient. So here, what about endometrial PRP?
Yeah, this is what we have most experience with. We are doing it since 8 years and increasingly more. Firstly, only in patients with atrophic lining, where the lining wasn't growing, and then we saw that it was helpful even in patients where the lining wasn't growing better. And that was the moment when we started to apply it even in patients with repetitive implantation failure and repetitive miscarriage. And the study to prove that it's really efficient is still pending, but this will come. This will come. We will prove it someday. For now, me and all my colleagues, we are 100% sure that it works. It's not a spectacular effect. It's not that. It's not a game changer. Otherwise, we would apply it in all patients, even before the first treatment. But it clearly helps, especially in patients where we have these adverse factors like atrophic linings or linings where no embryo is implanting. This is where it is supposed to be most helpful.
All right. Again, thank you so much for your addition to this question, of course. And let's see, next question, short one. So for frozen embryo transfer, when should PRP be done?
Well, I understand that this person is asking about endometrial PRP. So we perform the infiltration, means injection by hysteroscopy, right after the bleeding, when the woman is bleeding little or when she's already stopped bleeding. So we usually schedule it with birth control pills. That helps a lot. You can trigger a bleeding normally a week after stopping a birth control pill. This is when we perform the hysteroscopy, which is also, it has a good purpose. Hysteroscopy is also always an interesting thing to do in IVF. If you detect a polyp, you can take it out in the same procedure. If there are adhesions or Asherman syndrome, you can cut the adhesions in the same procedure and then infiltrate the PRP. So it's really interesting. And then we apply the instillations, where the washings, let's call it washing or lavage, with the PRPs during the growth of the lining between day 10, 15, more or less, every 3 days, and finally the transfer. So it's kind of a transfer cycle, a cryotransfer cycle, with the difference that we do the hysteroscopy on day 1 and the installations on day 8, 11, 15, more or less, of this cycle.
Brilliant. Thank you indeed for that one more question. Sorry. Okay. For someone with multiple implantation failures, will PRP be advised for next treatment with embryo donation? I'm 45.
Yeah, it's not so much the age, because I understand that embryos are there. So when it comes to implantation failure, it's not an official protocol at our clinic, but we usually recommend PRP after the third, sometimes already after the second failed embryo transfer, regardless whether it's implantation failure or miscarriage. After 3 failed treatment, this is, if it were easier to apply and if it would require less time and availability, and its costs are also an important factor here. So if all this were easier, we would do it much sooner and more frequently. The problem is that it's really cumbersome, and in order to do the whole programmation, you need to be on holidays. You have to come here for 2 weeks, because it's not. You have to come once for the hysteroscopy, which is a very short trip. You can come and leave the same day, but then you have to come here for the installations. And the installations, if you do 2 installations, and then you have to wait for the progesterone to take effect. So the whole stay is at least 12 days. This is what's, or you travel forth and back, which is also difficult. So that's why we don't do it more often, because of logistic reasons, basically.
Okay, and there's a follow-up for this this question is actually, if no hysteroscopy is required, already done recently, when would you perform uterine PRP?
Okay, it's the indication to do the hysteroscopy. The main indication is to apply the PRP in the place where they're supposed to be most effective, which is in the basal layer of the uterus, of the endometrium. This is where the endometrium is formed. So it's also from experience, we can say that this is most probably the most effective part of the PRP treatment, more than the lavage, than the washings. So we with the hysteroscope, we infiltrate the PRPs in more or less 10 different places all over the cavity. And we also can prove that it works when we do the first scan. We can see major part of the times we see a clear increase of the thickness of the lining. So it is a verifiable effect, and most probably more effective than the washings. When we do the whole program, we do both. We do first the infiltration and then the washings.
Okay, brilliant. Thank you so much. And now we have a little bit of a detailed question here. Best ways to put PRGF into the ovarian cortex and how to control the hormonal levels. Do you use, I'm not sure here, sorry, stem cells also?
Okay, the PRPs are infiltrated in not in a specific place. It's like in the center of the ovary, rather close to the cortex, as she saw, but not directly, not specifically in the cortex. And then the hormone levels, we control, as I mentioned before, we control AMH, FSH. These are the 2 main hormones that we determine to see whether PRP has taken effect. And the second part of the question is a no, at least not yet. We are regenerative medicine is the future, so a lot of things will come in the future. We will also open, but not soon. It will still take some time till we will open a new building with dedicated exclusively to regenerative medicine. And this is when we will also start to investigate with stem cells. But right now, it's not yet. It's something to come. It will come.
Okay, thank you. Okay, let me have a look. So yeah, this is a comment. What a blessing for the lady who had
Yeah.
for sure.
I would like to tell these stories more often. I would like to have more cases. Unfortunately, I have to. I'm totally sincere. I have many more failed cases, also because we apply these treatments in patients who are struggling to achieve. Patients where we apply these treatments are really difficult cases. So
that's how it is, unfortunately. But thank you so much for this comment as well, of course. And so if there was no effect after first PRP, would you recommend trying PRP for a second time? Can PRP cause negative effects on ovaries?
No. Well, let's answer the first part. Yeah. It's not clear whether applying it a second time would help. Sincerely, I don't have experience with that. When it has failed once, usually this is often a moment where it becomes clear, or for many women it was already clear, but they needed to try at least once a PRP to take the decision to go for egg donation. So I have not yet applied PRPs twice when there was no effect in the first attempt. There's no reason to think that the second attempt would be more successful. So I wouldn't try it a second time. And applying PRP several times, no, there is absolutely no side effects at all. No harm to the ovary, no side effects at all.
Okay, and actually there is again a follow-up here. So is PRP safe in terms of whether or not it can cause cancer in the future?
Okay, this is important for all patients to know. There cannot be a history of cancer, especially ovarian cancer, because we are infiltrating growth factors.
Right.
Growth factors would also apply to cancerous cells, obviously, which we don't want to grow them. And it's not recommended to apply it in women who have endometriosis in their ovaries. These are contraindications.
Okay.
But there is absolutely no evidence of causing cancer. If there is a cancer or even an initial cancer, it could trigger a stronger growth of that cancer, which is already present, but it couldn't cause a cancer.
Okay, thank you for your questions. More questions are coming. So let me show you this a little bit of a detailed one. I'm relating the game. I thought that maybe I could do ovarian PRP before natural cycle so that I can do a transfer for the embryos that I have already banked. Should I ask the doctor to also apply to my uterine lining in addition to the ovarian lining at the same time? How does that process look? I am 45 and have two opportunities for transfer. I want to maximize whatever is left.
Okay, so she has embryos. Okay, the embryos that I have already banked means that the embryos are already generated. So we are speaking about endometrial regeneration. So this is, when it is the decision whether to do or not an endometrial infiltration of PRP. There are indications for now. We have not yet started. We have not yet applied PRP even before the first embryo transfer. This is not an indication. It's not clear whether in this group of patients it's useful. There are so many things you can do in medicine. If you apply or diagnostic methods, for example, if you apply them to all patients, it's likely that it's not so useful because many patients just don't require these kind of treatments to have a successful implantation. That's why I wouldn't recommend it if you've not had implantation failures before. On the other hand, it's a very safe procedure. It's applied with a hysteroscopy, with a superficial anesthesia. It's a short anesthesia. It's very easy to apply. So if you ask me, would you personally do that? Let's say me and my wife, we have 3 embryos banked here and we want to start to transfer them. Would I personally apply this even before the first embryo transfer? The answer is possibly, because I know that it doesn't cause harm. I know that it doesn't have side effects. But there is no official indication to do that. No.
Makes sense. Again, thank you so much for this. And let me show you next question. So I did PRP, ovarian PRP. Unfortunately, it doesn't seem to have worked. Is there any suggestion what I can do to improve egg quantity?
No, because PRP is right now the most effective way to increase egg quantity, egg yield. When it works, when the ovary becomes more active and gets prepared more antral follicles, we can stimulate only the antral follicles that the ovary decided to get prepared. So if the ovary gets more active, we can achieve a higher egg yield. But there's no different alternative treatments. The other participant mentioned the transplantation of stem cells. This is very experimental yet, so there is very little experience, but this could also be a promising approach. I don't know whether in the near future stem cell transplants will have a much better effect. But right now, there's no good alternative to PRP.
Okay, thank you. Indeed. You've answered this, but how long does the effect of endometrial PRP last?
Probably not more than 6 months. I mentioned that the effect takes between 1 and 3 months, more or less, but could be that the effect holds up to 6 months. I mentioned one case of a young lady which had premature ovarian failure, so she was menopausal. She started to have periods a month after the PRP application, and we don't know for how long she would have had, but I think it took 4 months. She had periods for 4 months. So, but it has probably the effect might be longer, up to 6 months probably.
Again, thank you. Okay, and this is again a comment. Yes, I know from personal experience, PRP helped me to get from 3 millimeters to 6.5. Needed 3 sessions, 1 per month. Unfortunately, embryo transfer did not result in successful pregnancy.
Yeah.
I'm in mid-50s, not giving up though. Okay.
This is a typical case. It works in many patients. It's more the verifiable effects can be seen in more patients than with ovarian PRP. I would say 70% of cases declining, the lining clearly grows much better than before. And even in cases where the lining is not growing better, it's supposed to improve quality, but we have to keep in mind that a successful treatment, there are many other factors implied here. I'm speaking about the process of placentation. When the placenta is formed, this is basically what implantation means, because implantation is not yes or no, but it's a process. It's when the placenta is formed. Between week 4, this is when it started to implant. Officially, it's week 4. 10 days after the transfer, this is week 4. Up to week 8, 9, this is when the placenta formation takes place. And this is a process that fails so many times, even in young ladies. Age doesn't matter here. Okay, it's not if she's over 50, it shouldn't negatively affect the implantation, because the uterus is not aging as the ovaries do. But let's say we do a lot of egg donation here, so we transfer perfect embryos, and I would say that 90% of preparations are optimal, where we say, okay, we have a perfect lining, we have ruled out, we have done biopsies, we have done a hysteroscopy, sometimes even PRP, and still many of these really, I'm so optimistic on the day of the transfer, because I say, okay, everything was perfect, but I know, and I also say my patients, it can fail. Many embryos fail to implant, and we don't know why. There is so much to investigate yet about implantation. And how do you investigate implantation? You cannot investigate on pregnant women. You cannot do clinical trials, or you cannot take cells of an embryo that is growing in a lady. You cannot do that. There's so much to investigate. We know very little about the process of implantation. So the only thing we know is that roughly speaking, half of the embryos make it to become kids. Implantation is much higher. It's around 70%, probably the media. When everything is perfect, when the embryo is perfect, coming from young ladies, like when we do egg donation, and when the lining is perfect. So this woman who's asking, she's probably doing egg donation because she's over 50. And the only way to make this happen is to try again. If there is no significant issue that we can detect, she's probably done these exams like biopsies, and also hysteroscopy is recommended. If these exams are done, then it should happen. It should happen. But some couples need more than 3 attempts.
Okay.
Yeah.
Again, thank you so much indeed for that. And as always, best of luck to you. Okay.
Yes. Yeah.
Fingers crossed for sure. And we will be slowly finishing. Yeah, there's a comment. Absolutely, I'm trying again. And you are quite right. It was a donation. All right. Thank you so much. As I mentioned, we will be slowly finishing. So if you have any questions left, go ahead, type those in. There are like 3 of those or 2 of those left. Okay, as far as I know, PRP is applied vaginally and laparoscopically. And in which case would you recommend the one over the other?
Well, there's no reason to apply it laparoscopically. Why should you do that? It's much easier to pass a needle through the wall of the vagina because the ovaries lie right behind. So it's like an ovarian puncture. Why would you do this by laparoscopy? Laparoscopy is much more cumbersome. It's a bigger surgery than an ovarian puncture. So we never use laparoscopy to apply PRP.
Okay, thank you for the clarification to this. And let me just go to probably our final one. Would you recommend endometrial PRP washing in repeated implantation failure?
Yes. We have also had many patients who did just the washing. The whole program is infiltration and then installation or washing. But we have had patients who've done only the infiltration. We have had patients who've done only the washings. And it's probably not as effective as the complete program, but it's supposed to also take some effect. Otherwise, we wouldn't do both. The washings can also be very effective in some cases. Yeah.
Okay, thank you so much indeed. And let me just have a look regarding if you have one more question, I believe. Sorry, there are some comments, and let me just see. So practically, if you have embryos and optimal endometrial surrounding, you would go on until it implants.
This is a very personal question. How many times to try? It depends on so many factors. Age is one of them. How you take your life, whether it's the task of your life to have a kid, or whether I have also couples who say, okay, if it has not happened at the 3rd attempt, then it wasn't meant to be, and I'm totally fine. I will be happy without a kid. So how many times to try? In our clinic, for example, we have a 3 and a 5 blastocyst guarantee. And this is more or less what people choose to try it 3 or 5 times. And I think it's not, you might try more than 5 times, but I think this is the maximum. If it has not happened after the 5th attempt, then it has become clear that there is something, a really big obstacle for something that we usually don't detect. Normally, we just have to shrug our shoulders and say, we are sorry, we did everything, we fought very hard. All what we could rule out, we have ruled it out. We have thoroughly prepared each and every transfer, and still it's failing. And but the percentage of couples who do not succeed with egg donation is very, very low. Especially because you have the embryos guaranteed. If the first transfer fails, you have the second one guaranteed, and up to 3 times or up to 5 times, depends upon the treatment you choose. So okay. I wouldn't try it more than 5 times.
Okay, thank you so much for this. And actually, there is a comment here from our previous patient. So total of 7 times over 14 years failure, but not giving up. One more fresh egg donor cycle. Hopefully get 5 eggs.
Yeah.
Best of luck for sure. Thank you so much also for that comment. And as I mentioned, it seems that we will be finishing for today. But Dr. Park, as you can see, there are many thank yous coming up your way. Thanks a lot for an informative session.
You're welcome.
I got so much value from today, sending good vibes and appreciation. And there are many more of those. So very informative. Thank you so much for this session. I had to move mountains to join. Good to hear that you were able to join. And I also want to mention that if you missed any bits of this, don't worry, it will be available on our YouTube channel tomorrow morning, and also on our My IVF Answers website. The link is also in the chat. But if you subscribe to our YouTube channel, that way you will be notified that the video is actually right there and ready. So thank you so much, Dr. Pak. It was lovely to have you here today for sure. I hope you also enjoyed answering all the questions, lots of those indeed. And
Thank you. Sorry, just to say, everybody thanking me. Thank you to you all. It was a nice talk. I'm happy to give all this information. I think it's useful information, and yeah, if anybody feels the need to have a more thorough assessment of her case, you can get in touch with us, and we offer half-hour free assessments or orientative visits, which you can take an appointment calling our clinic.
Definitely, that sounds good as well. So thank you, everyone. And of course, remember that if you wish, if you wish to join, we will be back on Tuesday. There are more topics coming up. So thank you for staying with us today, Dr. Park. It was great to have you. Enjoy your evenings, and hope to see you back here quite soon as well. Take care.
Enjoy your evening too,
Bye.
and have a nice evening. Bye.